Well, good morning. Welcome to Statistics for Trauma Research Part 2, the revenge. Quantifying the extent of disease, this one, again, we're just doing some basics of trauma statistics, of statistics in general. Really wanted to get some basic terminology like prevalence and incidence, and talk about different ways to express the extent of disease and compare extent of disease between different groups. So first off, prevalence, and if you're a statistician or an epidemiologist and you hear somebody use the words prevalence or incidence in the wrong way, it's kind of like nails on a chalkboard. But prevalence basically is just the number of people who have a condition. So like the examples given here, 1 in 88 children have autism spectrum disorder. Arthritis limits the activities of nearly 21 million adults. So it's just a measure of the burden of the disease, the number of people who actually are dealing with it at a point in time. So it's the equation is simple. It's just for point prevalence. That's the number of people at a specific point in time who have the disease, divided by the number of people in the population, or the number of people that are examined in the group of interest. So for example, using our trauma data here for 2010 and 11. Looking at our female patients who are less than age 55, out of a total of 850 women that we saw, 90 of them were pregnant for just over 10%. And we can look at the different prevalences by the mechanism of injury and see that with violent injuries, over 14% of those women are pregnant, compared to 12% in the motor vehicle related. And of course this varies by age, even within the less than 55s, or the younger women, especially with violent injuries, tend to have higher prevalence of pregnancy. Certainly this is not something that we could appropriately measure using incidence, because that relies on new cases, and if they're getting pregnant in the hospital, that's probably a complication of some sort. So when are we actually, why does prevalence matter? Well, in the case of pregnancy, certainly you want to have some idea of how many women with that sort of condition. With our older adults and their anticoagulant medications, we want to have some idea of what the burden is going to be. This is an example from in a disaster type of a setting. During Hurricane Katrina, where we had millions of evacuees, had to shelter a whole lot of those people. And there was one shelter that had more than 6,000 people, and we knew that the prevalence of diabetes in that area was about 11%. Most people who had diabetes had a few days worth of medication with them, but some didn't. And so out of over 6,000 people, we knew there would be over 600 people with diabetes, and that ended up being one of the big issues to deal with for the people responding to the shelter, having to find enough glucose meters and medication for the people who needed those. Incidence, in contrast to prevalence, is the actually new cases of disease. So measured by new diagnoses or new incidence of disease. The example here is just the estimated rate of new HIV infections in 2009 nationwide. And you can see how that can vary by race and ethnicity. But there are two types. The definition is just the likelihood of developing the disease among people who don't have the disease and are at risk of developing the disease. So the numerator in both of these types of incidence, these measures, is the same. It's the number of people who develop the disease during a specific time period. Usually we say per year or something like that. But there are two different ways of measuring this. Cumulative incidence is the first one, and that's where we're just comparing that with the number of people who are in the sample or in the population. So that's divided by the number of people who are at risk at that baseline time. if we want more information and we're not able to follow those people for the entire time period, we calculate what's called an incidence rate. And that's where we incorporate the lengths of time that each people contribute to the denominator. And I'll have a couple examples of this. So cumulative incidence, usually we need to know, we need to be able to follow all of the participants for the full length of time. But incidence rate uses that person time data. Usually we express that as a number per 1,000 person years, or per some unit of person years or person months as appropriate. So to take another example from the trauma data, looking at ventilator-acquired pneumonia as a proportion of the total number of people who are ventilated. We see the cumulative incidence of VAP for the 0 to 49-year-olds was 10 out of 176 who were actually ventilated, so 5.7%. Looking at the older patients, there were 117 on vent. 7 of them developed VAP. So that incidence is 7 out of 117, or 6%. So actually not a whole lot of difference by age with this, but that's a good measure of incidence. If we want to, we know that the longer somebody's on a vent, the more likely it is that they're going to develop ventilator-acquired pneumonia. So it might make sense to look at the lengths of time that they're on vent. So that's why an incidence rate might be more appropriate for this. So in this case, instead of using the number of people who were ventilated, what we use is the total number of vent days. So the number of days cumulative that people were on a vent. And again, the numerator is going to be the same. It's just the number of new cases of VAP, but now the denominator is the total number of days that people were on a vent. And so calculated basically the same. Our younger ages, we still have 10 people, but they were on for 857 days. So for an incidence rate of 11.7 per 1,000 person days. Notice before I mentioned person years, the person time can be whatever unit is appropriate, as long as you specify what the person time is. And over 50, it's 7.6 per 1,000 person days. Now this doesn't give the entire picture, but it's a little more descriptive than cumulative incidence. When we talk about survival analysis later on, we'll get a little more into this. I took a little closer look at this data, and because for example, for the first 2 days, there were no cases of VAP, because it takes some time for that to develop. And that also encompasses about a third of the total person days that people are on ventilators, and about half the people are on for about that length of time. So that many people really are not at risk yet. But just kind of brings home the point that the more detailed you can look at the data, the better in terms of understanding it. There is a relationship between incidence and prevalence. I use the analogy of the bathtub. And there's a fairly simple equation where we think of prevalence being a function of the incidence and the duration of the disease. So the number of people with the disease is a function of how frequently people contract the disease and how long they have it. So like with the bathtub, incidence would be the faucet, the water coming out of the faucet, and duration is just how long the water's actually in the bathtub and how wide the drain is open, letting people come out. So as incidence goes up, of course, prevalence is going to increase. As the death rate goes up, that means duration is getting shorter, and so prevalence is going to go down. We can calculate a good estimate of the number of people that we actually have hospitalized. Based on the number of admissions per day, we get about 7.3 people admitted to trauma per day, and the mean length of stay is about 3.8 days. So on a typical day, we have about 28 people actually in the hospital. At in some stage of care. So that would be the prevalence. Okay. Now, that's all well and good, but often we need to compare two different groups with each other. Then there are essentially two ways to do that. We can subtract or we can divide. When we subtract, that's called the risk difference, and there's a couple different names for that. We can think of it as the excess risk or attributable risk. Or we can actually look at relative risks or odds ratio if we want to see proportionally how much higher is one group than the other. Now, to talk about the risk difference, also known as the attributable risk or excess risk, the concept is that people who don't have the exposure that we're concerned about have a certain baseline risk of disease. With any disease, even like lung cancer, people who have never smoked a cigarette in their lives have a certain risk of getting lung cancer, baseline risk. The example here is for coronary heart disease, where non-smokers have a baseline risk of 17.4 per thousand. And in smokers, though, the risk is 28 per thousand. So, and we can separate that into that baseline risk that is the same as the non-smokers that they would have had whether or not they smoked, and the additional risk or the risk difference. And so if out of that 28, 17.4 is going to be due to that background or baseline risk, and the additional 10.6 per thousand is due to smoking. And the other way of thinking about attributable risk or the risk difference is that proportion of disease that can be attributed to that risk factor, or that the amount that can be done away with if that exposure was eliminated. So the equation is just the incidence rate in the exposed population minus the incidence rate in the not exposed. And the example we have here actually comes from San Diego County SWITRS data. SWITRS is the statewide integrated traffic record system. This is car crash data. And so in looking at the proportion of people who died and whether or not they used a seatbelt. So in 2009, those who actually used a seatbelt, we had over 13,000 people in injury crashes. 72 of them died in that collision for a death rate of 0.54% in that group. Those who did not wear a seatbelt, we'll think of them as the exposed group because they're exposed to the more dangerous situation. There were 475 of them. 38 died for a death rate of 8.7%. So the attributable risk there is that 8.7 minus the 0.54 that we saw in those that were actually using safety restraints, for an attributable risk of 8.16%, attributed to not wearing a seatbelt. There's another measure called the attributable fraction, where you can say the percentage of those who died that was due in the exposed group that was due to the exposure. And so that's where we just take the attributable risk and divide that by the total risk in the exposed group. So in this case, that's that attributable risk that we calculated, 8.16%, divided by the 8.7%, which is the risk of death among those who didn't wear a seatbelt. And we get almost 94%, meaning that 94% of those deaths in people who were not wearing seatbelts could have been avoided if they had just worn a seatbelt. Now, from a public health perspective, often we want to know, okay, how does this affect things on a population scale? Because if the exposure is something that's not particularly common, it might not really affect a whole lot of people. But what we want to know is how many deaths in the whole population could we prevent by getting rid of this exposure? That's called the population attributable risk, or population attributable risk percent. And that is calculated exactly the same as the attributable risk that we used looking at the exposed population, except now instead of using the exposed population incidence rate, we use the total population. So the incidence rate for the overall population, and subtract off the incidence rate for the unexposed group. So that's the proportion of disease or injury in the whole population that could be reduced by getting rid of that risk factor. And going back to the example of seatbelts, well, now what we're interested in is the total amount of death, the total number of crashes where seatbelt use is known. And we find that now, of course, that's going to be the sum of all of these, where seatbelt use was or was not worn. And we've got nearly 14,000 crashes, 110 deaths out of that. So the population attributable risk is going to be that 0.8% minus the 0.5% that we saw in those that actually were wearing a seatbelt. So not quite as impressive as those that weren't wearing seatbelts, but still 0.26% of those were due to not wearing a seatbelt. And to get the population attributable risk percent, we just take that divided by the population's risk of death in a car crash, and find that nearly 1/3 of all deaths from a motor vehicle crash could have been prevented if everybody had been wearing a seatbelt. So still pretty powerful measure. Okay, so that was attributable risk. Again, the amount of disease or injury or death that is due to an exposure. Relative risk is where we're saying a certain exposure doubles your risk or has some proportionate increase in risk of disease or death. Examples here: cannabis can double a driver's risk of a serious crash. Divorced men are more than 8 times more likely to commit suicide than divorced women. And dense breast can nearly double the risk of breast cancer recurrence. And that's what we're getting at with relative risk. It's simply the incidence rate in the exposed group divided by the incidence in the unexposed. Just the ratio of those two incidence rates. If you like visuals, we can think of this as just being incidence of disease and exposed is where we divide this 2x2 table into cells A, B, C, and D, where A is exposed with disease, and A plus B is the total number of exposed. Incidence of disease in exposed is A over A plus B, not exposed C over C plus D. So the relative risk is just a ratio of those two incidences. Okay, so going back to our example of VAP, and the stratifying by age wasn't particularly exciting, so I looked at whether or not they were intubated when they were admitted, and now we see that those that were intubated in resus had a risk of developing VAP of 7.8%, 5 out of the 64 that actually were intubated in the resus room, compared to 12 out of 229 that were not, 5.2%. The ratio of those two risks is 1.49. So we can interpret that as saying the risk of VAP is 49% higher in those that were intubated on admission. Obviously, there's much more to it than the simple act of intubation. They're probably much more severely injured, and other factors going on. All right, odds ratio is related to relative risk, but it's somewhat different. It's something we calculate usually when we can't calculate a relative risk, and conditions for that are usually when we're conducting a case control study. And I'll talk a little bit about why you can't calculate a relative risk in a case control study in a minute. But first we need to understand the difference between probability and odds. Probability is just a proportion. It's the proportion of the total events that result in an outcome. So if you flip a coin 100 times, you get 60 heads. And the probability of getting a head on a coin flip, we can calculate as 60 divided by 100, or 60%. Odds, on the other hand, is the ratio of the number of successes to the number of failures. So the number of times something does happen to the number of times that it doesn't happen. And so, so using the same analogy, 100 coin flips, 60 heads, the odds of getting a head is the ratio 60 to 40, or 1.5 to 1, or simplifying down to just 1.5. And using our example of VAP again, probability of VAP for those who were intubated on admission is 5 out of the 64 who were intubated, but the odds of developing VAP is 5 divided by 59. And essentially the odds ratio is just the ratio of the odds in the exposed to the odds in the not exposed. And this is technically what the equation is: the incidence in exposed divided by 1 minus the incidence in the exposed for the odds in exposed. Likewise for the unexposed. And if you want to use that same 2x2 table to calculate an odds ratio, technically it's the proportion of the exposed who get the disease divided by the proportion of the exposed who do not have the disease. However, since the denominator in both of those is the total number of exposed, that cancels out, so that simplifies just to A divided by B. Similarly, with the not exposed, the total number of not exposed is in the denominator of both of these. That cancels out, so that simplifies to C over D. Usually, the equation that people use for calculating an odds ratio is called the cross product. So it ends up being A times D divided by B times C in this type of a table. All right. So looking at relative risk versus the odds ratio, when we have full data, when we have all of the data, we may as well calculate the relative risk. And in this case, that's again that 7.8% divided by 5.2% risk of VAP, depending on whether or not they were intubated in resus. And so we get a relative risk of 1.49. Odds ratio, again, is the odds, so 5 over 59 divided by the 12 over 217. And you can see that it's pretty close, but it's a little bit different. The reason we would calculate ratio is if we're doing a case control study. And so in this example, let's say we've still got the same number of people with VAP. So those are all of our cases. But now we decide we want to match them 2 to 1. So we want to get 2 controls for each case. So we draw 34 controls who did not develop ventilator-acquired pneumonia and find out whether they were intubated in the resus. If we were to calculate a relative risk on this, we would need to be able to calculate the incidence rate for each of these groups. Because we basically manipulated the numbers here so that we intentionally drew only 2 controls for each case, we have artificially inflated the proportion of people who have the outcome And so in this case, it appears that 33% of our sample actually has VAP, which of course is not the case in the real world. And so likewise, the rates within each of these exposure groups is also going to be elevated. So we really can't use that now to calculate a relative risk. So case control study, we can't do that. But what we can do, if each of the cases and controls is representative of all cases and controls, we can measure their risk of the probability that somebody who has the disease had the exposure. So we can measure it the other way and calculate that probability. So in this case, 29% of those with VAP ended up being intubated in resus, and 24% of those who did not develop VAP were intubated in resus. The reason we can actually use an odds ratio, so what we're interested in is not the probability of having the exposure given disease. What we're interested in is the probability of developing disease given exposure. The reason we can we can use the odds ratio as an estimate of the relative risk is because the result ends up being the same no matter how you calculate it. So if you do the 5 divided by 12 divided by 8 divided by 26, we get 1.35 for that. If you calculate it the other way, so 5 over 8, the odds of having VAP given intubation, divided by 12 over 26, the odds of having VAP given not intubated, you also get 1.35 in this example. So it's calculated exactly the same way. You get the same exact answer either way that you calculate it. That's why the odds ratio is a reasonable estimate of the relative risk in a case control study. And you technically you can calculate an odds ratio in any type of study, but with like a clinical trial or a cohort study or something that's population based, usually relative risk is easier for people to understand, and so that's why we calculate relative risk on those. So just to recap that, it's not possible to estimate a relative risk in case control studies, so we use the odds ratio because it's calculated the same way because of that invariance property. Okay, so just to recap what we've talked about, prevalence is people who are living with disease. It's a measure of the burden of disease and the demand on the healthcare system. Incidence is new cases of disease. So we can calculate incidence to talk about to be able to measure risk factors for developing disease. And there are two types of incidence that we talked about. Cumulative incidence is the number of new cases divided by the population or the total sample. So the denominator there is just the number of people. Incidence rate, the denominator, is the total amount of person time that's at risk. And prevalence is a function of incidence and the time that people have the disease. So prevalence is incidence times duration. Attributable risk is the incidence that is due to, or sometimes people use prevalence, that is due to a particular risk factor or the amount that could be eliminated if that risk factor was gone. Relative risk is a ratio of the incidence in exposed to incidence in the not exposed. Unfortunately, we can't calculate that in case control studies because we have artificially inflated the proportion of cases of people who have the disease. But we can use odds ratio in case control studies. So that's the ratio of exposure of the odds of exposure in cases to the odds of exposure in controls. So we do use that in case control studies. All right. And next time, we will meet back here on October 2nd. We're going to go a little bit deeper into the magic of statistics, and talk about probability and a few specific distributions, specifically the binomial and normal distribution, and talk a little bit about the central limit theorem.